Start recording.
Okay.
There it is. Yeah.
Okay, let's start. And also we can share also the record session to our professionals, those who are unable to attend the online one.
Excellent. Good morning, good afternoon, everyone. I'm Mauricio Galvão. I'm a nephrologist and the intensive care physician. I'm a part of the DTI team, and today I have a pleasure to moderate this webinar about organ assessment and acceptance. And I'd like to present Dr. Pedro Ventura. Dr. Pedro Ventura is a transplant nephrologist at the hospital clinic in Barcelona, and responsible for is the lead of the pancreas transplant program, and work in the many research areas in the hospital clinic. Thank you, Dr. Pedro, to accept this invitation, and you have 40 minutes or 45 minutes, Carlos, to present, and then after we will have 15 minutes to discussion. Thank you, Pedro.
Sorry, now. Thank you, Mauricio, and thank you, DTI, for the invitation. It is a pleasure to share this upcoming hour with you, in which I will try to. It was a challenge to make a whole and grab a whole. I'll try to give you an overview of to do organ assessments. Particularly, I'm a transplant nephrologist, as Mauricio mentioned, and therefore most of the my presentation will be regarding kidney transplants and kidney transplant assessment prior to transplantation and how potential implication on the outcomes. And I'm happy to share this presentation with you. I think I'll just share the entire screen. It might be easier, and then just turn on my presentation. Okay. Okay, I assume you can see the screen.
Excellent.
Perfect. So just as a mild introduction, why are we talking about this, about organ assessment, and what's the relevance of it for our clinical practice? We know that chronic kidney disease, and again, I'm a transplant nephrologist, so the focus will be a lot on kidney disease, and moreover, is the most frequent transplant performed worldwide. And we know that chronic kidney disease is an epidemic, and we might assume that it is an epidemic in Western countries related to lifestyle changes, but it has also been increasingly frequent in other countries. And you can see here Oman, where you have a very high and most importantly, an increase in recent years in the number of patients with advanced chronic kidney disease. I think the terminology end-stage kidney disease is misleading. It leads a lot to cancer, so we try to change our semantics and to advanced chronic kidney disease, and it's definitely increasing worldwide, and Oman is no exception to this. And we know that it's one of those silent diseases that does not have the same focus from the general population, from the media, and often from the medical community as well as other diseases such as cardiovascular diseases. But the burden on the quality of life and on the impact on life-changing years is very significant compared to these more mainstream diseases. And you can see here, and if we look here at North Africa and Middle East, the impact on the quality of life, on the age-adjusted quality of life, is higher than ischemic heart disease and much higher than stroke. So in both combined, it's almost the same impact as these two diseases combined. So it's definitely one of those silent diseases, one of those silent epidemics that needs to be paid more attention, and we need to address. And I think that's part of the reason why you're connected today, because you're already aware that this is a problem needed to be addressed. But part of addressing the chronic kidney disease issue is through dialysis. We know that dialysis has significantly extended the life of our patients, and I think at some point is also our major burden is the fact that our patients no longer die from chronic kidney disease because we have dialysis, and we assume that these patients no longer die from chronic kidney disease. But dialysis, particularly in the highest prevalent disease that is leading to chronic kidney disease, such as diabetes, mostly type 2 diabetes, has a major impact on patient survival. And you can see here on the right that patients on dialysis that don't have diabetes have a much better survival on dialysis and a much better quality of life compared to those patients that have diabetes, regardless of whether diabetes was the cause of chronic kidney disease or is just as a comorbidity. But still, the mortality on dialysis is significantly inferior. So even though we talk about chronic kidney disease and we talk about dialysis, we need to take into consideration that transplantation is the best treatment alternative for patients with advanced chronic kidney disease. It increases life expectancy, improves quality of life. It optimizes resources because you can only have one patient connected to one dialysis machine for 4 hours, whereas in the same time period, a doctor in the outpatient clinic can see at least 5, 6, 8 patients in the outpatient clinic with a functioning kidney transplant. So it also optimizes resources. It reduces the costs because the cost of one dialysis treatment for 1 year is the same as for a kidney transplant overall. And therefore, beyond the first year, the cost saving of a patient with a functioning kidney graft is much higher than maintaining those patients on dialysis. So transplantation and from the perspective of survival, function, medical perspective, and also economic perspective, is definitely the best treatment alternative for patients with advanced chronic kidney disease. And this has led to our standings currently, where we see that worldwide, there are performed about 144,000 solid organ transplants, with the most of them being kidney transplants. You can see here that almost 70% of the transplants performed worldwide are kidney transplants. And you can see that most of them come from deceased donors. But a lot of countries and centers have focused on living donation because we know that living donor provides the best kidney transplant outcomes. And definitely living donation is one alternative. And I apologize here for the misplacement of this. I don't know why it moved, but you know that living donor only solves part of the issue because living donors represent even in the best countries only about 50% of the transplant activity. And therefore, we still have at least half of the population, and in several countries have up to 80% or 90% of the population that don't have access to that living donor. And you can see here Oman with the rate of living donor of about 2%. So deceased donation is definitely the best approach for kidney transplantation. We have a higher source of organs if we evaluate the donors thoroughly and accurately, if we maintain the donors, and if we have a very established program for organ donation. So it allows us to expand the number of transplants we are able to perform, and therefore the number of patients that we're able to treat and increase their quality of life. So you may say that, okay, you can see here Spain in this very dark red, you can see here United States in the dark green, you can see here United States very dark green, and then you can see other European countries, for example, in a much lighter green. And you can say, okay, but this is because Europe or the northern USA, North America, you have more resources, and it's about the money because disease donation costs money because you have to have a procurement team, you have to have a coordinator, and then you have to have all the logistics associated with disease donation. And you can see Spain, we didn't come straight from the top. We have come a long way in the last 40 years. And you can see that this increase, we moved from about 14 donors per million people to more than 40. And this year we reached the 50 donor per million people. And you can see, but this increase was steady. We have come from down low, and we have at a steady state moved towards increase our organ donors. And it's not about the money. You can see here Spain with one of the highest rate worldwide on organ donation. But when we compare ourselves to Germany, and for us Europeans, Germany is usually our reference towards GDP per person. And you can see that Spain has almost 5 times more donors than Germany. And Germany has 3 to 4 times more ICU beds than we have in Spain. So it's not about ICU, it's not about country income, it's about logistics. So, and it's important that these logistics, we are aware that these donors can become multi-organ donors. This is what you see here in the blue line, that 70% of the donors in Spain become multi-organ donors. And this is what allows us to increase not only in our kidney transplant, and that's disease donation. The advantage of disease donation compared to living donor is that you can increase not only our activity on kidney transplantation, but you can also increase, and you can see here, all the organs, the kidney, the liver, the heart here, have increased their number of transplants based mostly on disease donation. And as we talk about organ assessment and kidney transplant, we tend to think about younger donors. That's where the inception of kidney transplant started. That's where the inception of deceased donor kidney transplant started, is on younger donors. But as the years went by here, since the 50s, where the first kidney transplants were performed from the twins in Boston, then as the years went by, you can see that the age of the overall population has increased. And that has also been associated with an increase in the age that patients reach advanced chronic stage kidney disease. And that meant that we had then a lot of older people on dialysis because they were no longer acceptable for a deceased organ donor transplant because of their age and because donors were younger. But we know nowadays that our conception of being 60 is different than it was in the 60s. And we know that nowadays, 60, 70 years old, people get at their age, at that age, with much more active, less fragile, with a more active life, sometimes social life, sometimes even work life. So therefore, it's important that we realize that we need to expand and we need to keep our mind open when we talk about organ transplantation, not to draw a line on the age and adjust to our age population and to the population that we have with advanced chronic kidney disease. So that has led a lot of centers to, in the early 2000s, to coin the term of expanded criteria donors. Expanded criteria donors, and you can see here, were donors that were older than 60. So anyone that was a potential organ donor older than 60 was already considered an extended criteria donor, or if they were older than 50, but had at least 2 of the following: hypertension, cerebral vascular disease, or acute kidney injury at the time of organ donation. But when you look at our data here from the donors in Spain, you can see here donors more than 60 here in the blue, orange, and this light purple. You can see that they represent already more than 50% of the donors in Spain. So if we look strictly to the donor age, we would say that more than 50% of the donors nowadays are considered expanded criteria donors. So how do we evaluate these donors? And the reason for us to increase on this acceptance of older donors is because when we look at the recipients, we see the same tendency. We see that we have been able to treat chronic kidney disease better at younger ages. So our patients progressed to advanced chronic kidney disease when they are already older. And you can see that the recipients match the donors. 47% of the recipients have more than 60 years old at the time of transplantation. You can see here already a large number of patients over 80 and a very large number of patients over 70 years old. So we have moved towards calling them expanded criteria donors to they're becoming almost our standard donors nowadays, because more than 50% of our donors have more than 60 years old. So how good are these organs for transplantation? Can we accept them? But we keep in mind that this increase in organ donation, you can see this halt here between the 2000s, where we reach about 35 donors per million people, and we kind of got in a steady state there, more or less at that time point. And then you see this second surge here when led us to reach these 50 donors per million people. And the second surge was when we realized that we were becoming this age limit, this external criteria donor limit on the DBDs. And that's when mastectomy donors, DC donor after cardiocirculatory death, came into play. And we have 5 types of DCDs. I forgot to include here the 5th, which are donors from euthanasia, from self decision to limit their life. And most of the donors we use for organ transplantation are DCD type 2 and DCD type 3. DCD type 1, they've never been attempted for organ transplantation. They seem to not be good organs for transplant. Whereas type 2, when there is an attempt for resuscitation, but it was unsuccessful after the attempt, after you stop the resuscitation maneuvers, you you realize that patient is unsalvageable. So that's when you then activate as a potential donor. And then you have type 3 when there is a planned cardiac arrest in a patient that is not able to also be on a self-maintenance and will not be able to survive if you stop all the support. So these are the 2 major types of donors that we use as DCDs. And you can see that, as I mentioned, from 2013 that they were introduced, particularly type 3. Type 2 was already included here, but particularly type 3. And you can see the surge in the number of DCD type 3 donors. And these are the ones that represent that second increase and that second wave of donors that we have since 2015. And nowadays, they currently represent more than a third and almost close to half currently of the donors that we have in Spain are DCD type 3. What about the outcomes? When we look overall to the main results, we can see that both type 2 and type 3, they present similar outcomes compared to graft survival and patient survival on the long term. When compared to DBDs with donors after brain death. But there is the need to evaluate these organs, and how can we decide from particularly for these extended criteria donors and for these DCD donors, which organs will be suitable for transplantation, which organs will have a primary graft function, and which one will have good long-term graft function. And to do that, a lot of groups and a lot of focus has been placed on trying to identify a pre-procurement biopsy scoring system. Pre-procurement biopsy means that at time of organ donation, a biopsy is performed to the donor kidney, either a core biopsy using a needle or through a wedge by making a surgical biopsy. And then this biopsy is analyzed, and the scoring system will give you on the major categories of the biopsy: glomeruli, interstitial, tubuli, and also on the arteries. These scoring systems have tried to provide information on whether or not we should accept those organs for transplantation and whether the acceptance of those organs is associated with a good outcome. The major issue we start already with pre-procurement biopsies that as nephropathologists are very used for evaluation of paraffin-embedded samples, but of this procedure for the technique is not suitable to have in a time frame suitable for transplantation, and therefore the major evaluation of pre-procurement biopsies usually performed on frozen section, which from a pathological point of view provides a very different perception of the sample, of the compartments that are under analysis, and therefore needs more expertise towards mastering that evaluation. And then there's the need to develop one scoring system that is reliable and is reproducible. And here are some of the scoring systems that have been described. The Remusi score, perhaps one of the most famous and most widely used. Then the Banff community, and I will go more in depth later on these 2 scores. The Banff community also came out with their own scoring criteria. and they try to correlate with outcome. And then there are another scoring systems that have incorporated not only the histological data, but some clinical data in order to predict the graft function on the long term. The Ramusi score, as I told you, was one of the first and most famous. It was published in New England in 2006, and basically evaluates 4 compartments: the glomeruli, the tubulointerstitial with the tubuli and the interstitial fibrosis, and also the vessels with the arterial hyalinosis. And they score from 0 to 3 on each of these 4 compartments, and then it gives us total scoring system of 0 to 12. In the original publication, it was meant that from 0 to 3, it was an acceptable organ for transplantation. From 4 to 6, it should be individualized. And in the original publication, what they considered was to do a dual transplant, the 2 organs on the same recipient, whereas a scoring system over 6, from 6 to 12, from 7 to 12, it should be not accepted for transplantation. And you can see that the outcomes overall, when they compare their scoring during the transplant using the scoring system, either a single or dual, using these categories, if they had 4 to 6, they would do dual, compared to those transplants in which they did not perform any biopsy, they didn't perform pre-procurement biopsy, they demonstrated that doing that biopsy increased and improved their outcomes on the long term. So the BANF came out with a refined version, perhaps we may say, of this Ramusi score, and they incorporated also more detail, like interstitial inflammation, not only atrophy but also fibrosis, interstitial inflammation, interstitial fibrosis. They also incorporated thrombi and the degree of acute tubular injury at the time of the biopsy, to see if they could increase the prediction on the organ outcomes after the transplant. But the first caveat that they identified was the fact that there was no agreement between pathologists, and we're talking about nephropathologists experienced that collaborate with the BANF, that do pre-procurement biopsies on a regular basis, but still the agreement between the biopsies was about 50% in the number of glomeruli that were sclerosed, or in the number of arteries, or in the interstitial inflammation. So the concordance between nephropathologists was really low. And the best concordance that they have was in the number of glomeruli. So even though the scoring system might be refined, the agreement between pathologists is low, so it will depend a lot on the pathologist that is on call at that time point. Moreover, we see differences whether the biopsy was a core biopsy or it was a wedge biopsy. And you can see already here differences between the agreements between the pathologists. And for example, the number of glomeruli that was sclerosed between a core and a wedge biopsy is almost double if it is a wedge compared to a core. Or again, on interstitial inflammation, you can see that the agreement is really low between the pathologist, and it also depends on whether it's a core or a wedge biopsy. Moreover, the ability to predict graft outcomes, and this is to predict early graft survival, it was rather low. You can see only a 4% more if you included the biopsy on the ability to predict the patients with basically which will present an early graft dysfunction. So despite all these detailed histological evaluation parameters, the correlation with early graft function was rather low. Similar with function at 1 and 2 years, and actually the only parameter that correlated was the number of glomeruli that were that had sclerosis. The other parameters did not have any correlation with graft function at 1 and 2 years. So it's important that to understand that it's giving you an information, but not necessarily being correlated with graft outcome. And you can see that clinical parameters like age, donor type have much higher correlation and much better correlate to graft outcome compared to the pre-procurement biopsy. So this has led other groups to try to understand whether if you incorporate these clinical parameters, it will improve the applicability of the pre-procurement biopsy, and this is from a group from Belgium, and you can see that if they incorporated some clinical parameters to the glomerulosclerosis, it correlated with graft outcome on the long term, as well as interstitial fibrosis, but not for tubular atrophy or arteriolinosis. Again, when they compared another group, the same group with the Remusi score, you can see that higher Remusi scores obviously have worse outcome, but you can see that here, both the BANF and the Remusi score, even though it was significant, the area under the curve to correlate with graft survival on the long term was rather low for both. Usually an AUC over 7 is desirable for any marker as prediction marker, and both the Remusi score and the BANF score had a AUC about 0.6. So despite these pre-procurement biopsies and doing a transplant, their ability to predict graft outcome is rather low. So why should we do graft biopsies? Moreover, you can see here that this group, what they analyzed was that pathologist is relevant towards the identification of this scoring, meaning that if you have an on-call pathologist that is not a transplant pathologist, they are likely to give a very similar score, whereas the transplant pathologist looking at the same sample will do different gradings. And these different gradings have a huge impact on outcomes. So you need to have trained pathologists 24/7 on call to do this pre-procurement biopsy. Furthermore, if you do these pre-procurement biopsies and you don't have a trained pathologist, it might lead you to an increase in the discard rate of your kidneys. And this is a study from the US where they evaluated according to the KDPI, and I will go to the KDPI in a few slides. But looking at the KDPI, which is a measure of organ quality, the centers that even in low KDPI had a very low threshold to do a kidney biopsy had a higher discard rate for organs. And you can see here the higher KDPI, the higher the centers will do a biopsy. This is each blue dot or red dot here is one center, one OPO. And you can see here the higher the KDPI, the higher the number of OPOs that will do a kidney biopsy. That is kind of expected. But you can see here that there are several OPOs in the US that actually still make a biopsy, even in kidneys with low KDPIs that would expectedly have good outcomes on the long term. And the translation of this is that if you do a biopsy in a kidney with a low KDPI, you're more likely to discard it than if you do a biopsy, if you don't do a biopsy, and you'll just accept that most of those kidneys. So you can see that doing a biopsy may lead to an increase in organ discard. So we need to look at the biopsies very carefully, because it increases our time towards transplantation, increases the cold ischemia time, because you do the biopsy, then you have to wait for the pathology evaluation, then you make the decision, and then you go for the transplant instead of just going straight to the OR to do the transplant. So pre-procurement biopsies may aid you in the diagnosis. But this study from comparing the US practices of doing the biopsy, waiting for the results, and then deciding to accept or discard, compared to a European cohort in which basically they did the pre-procurement biopsy just as informative. So they didn't have the result of the biopsy until after the transplant. They compared what were the outcomes. And what they observed was that the kidneys transplanted with standard criteria alone, this is the outcome. But when they compare the kidneys that were matched for the European cohort, that they did not wait for the biopsy to transplant, you can see that the outcomes are similar to the kidneys that had the biopsy and then were accepted in the US, meaning that doing the biopsy does not necessarily mean that you're going to have better outcomes compared to not waiting for the biopsy, just accepting based on the clinical criteria, and the biopsy will just provide information for the post-transplant period, but not for the decision making. So when we talk about pre-procurement evaluation, and I got 5 more minutes, when talking about pre-procurement evaluation, the biopsy might be a good, might give you good information, but we gotta keep in mind that it increases the costs, it increases the logistics, it may bias towards organ discard rather than organ acceptance, and it does not necessarily correlate with graft outcomes. So pre-percutaneous biopsies might be good for interpreting post-transplant outcomes, but not necessarily towards organ decision-making. So as I told you, the data was that the KDPI and the KDRI are indexes towards evaluation. How can we, at the time of a potential donor, predict what's going to be the graft outcome on the long term? And I mentioned that extended criteria donor was one of the major criteria used for several years, but then the US introduced the KDRI, the Kidney Donor Risk Index, in which through a mathematical formula, they included more variables than just the cardiovascular disease, serum creatinine, and time of donation. They increases also donor age as a continuous variable, diabetes, the race, which is now excluded from the KDRI, also the type of donor, if they had hepatitis C. So they included other variables, but rather as a continuous variable than just whether a positive or negative variable. And what they observed was that the KDRI effectively correlated with graft outcomes. The higher the KDRI, so the worse the organ quality, the higher risk for early graft failure, and also on the long term, the higher risk for lower graft survival compared to low KDRIs. So the point is, we should exclude all high KDRIs and just not accept them for transplantation. The answer is no. The KDRI is giving you a perspective of what's the potential long-term outcome. But it's important to consider that higher KDRIs also are associated with higher donors with higher risk, and they are usually transplanted to older recipients. And this is what this group from the Netherlands observed, was that even if you use a high KDRI, but you censor for patient death, meaning that death censored graft survival, you can see that the higher KDRIs behave almost as good as the ones with lower KDRIs, because these kidneys are being transplanted to older recipients. So the problem with these recipients is that these patients have a death with a functioning graft. So despite these misleading and sometimes somewhat deceptive results that high KDRIs have worse graft survival, they might actually just relate to the recipients that we're also transplanting these high KDRIs to. So the US also moved from KDRI to KDPI to be easier to understand and to be easier to put a number. And the KDPI, so they base on the KDRI, and they basically tell you that that organ is within the 20% most like best organs that we had in the last years. Or they are in the higher 80%, and so it's one of the worst organs that we've had in the last years. And based on that KDPI, on the quality of the donor and their position within the donors, they can give you a perspective of how long can you expect, if you transplant that organ, to last. And you can see that the higher a KDPI, here higher than 86, the lower the expected survival on the long term. So the thought process would be higher KDPIs, we should not transplant because the life expectancy of the organ is about 5 years. And you can see that the higher the KDPI, the lower it is, the higher is the discard rate, and the graft survival is lower as well. So the higher we have a KDPI, we're going to discard more these organs. And you can see here the survival, again, according to the KDPI, it is similar to the KDRI. The higher the KDPI, the lower the graft survival in the long term. And this is the correlation, and I will go through how the KDPI correlates with KDRI, and I show that more than 1.4 had the worst survival, and you can see here the KDRI, here more than 80%, they have about 2, so it's a very neat correlation between KDRI and KDPI. And similar to the KDRI, you can see that KDPI is higher here, again, in American cohort, you can see that have a lower long-term graft survival. But the culprit is here, is how do we match this potentially low functioning or less pristine organs to our recipients? Because we know that if we use an IKDRI on a 65-year-old recipient or older, we might have a good long-term outcome. And that's what this EPTS comes into play. Basically, the US, to try to match the donor to the recipient, they developed an estimated post-transplant survival score for the recipient based on 4 major variables. What's the expected life expectancy for this recipient? So if you have an organ that's expected to last 5 years in a recipient that is expected to survive 5 years, then maybe that is a good match. And that's what this group compared. They compared the survival benefit estimator with a high KDPI for a patient with a high PTS, and let's say here a PTS of 60, a KDPI of 100, still that survival, it's way better than remaining on dialysis here in very dark red, whereas compared here in light blue, it's very much better percent likelihood of survival at 5 years and at 10 years. And what they identified is that if you combine the KDPI with the PTS and you estimate the survival benefit, you see that you might be able to decide the best recipient for each organ to increase the life expectancy compared to letting these people on dialysis waiting for that low KDPI organ. They put this online, so it's available, and I let you hear if you want to look and estimate and try to explore in your potential donors and recipients whether this might have been correlated also in your cohort as well. There is a publication from Spain that correlated very neatly the survival benefit estimator with the survival of the patients. So it's a good estimate to match donor and recipient for the organ. So, and here I would like to conclude that we have to be aware that chronic kidney disease is an epidemic, and transplantation is the best treatment alternative for these patients with advanced chronic kidney disease. And for disease donation, we need to evaluate, we need to assess. We know that there are some clinical characteristics from the donors that influence on the graft outcome, but it's important that we match the donor outcome to the recipient outcome. And to do so, the pre-implant biopsy might give you relevant information, but not necessarily information that you might use to discard the kidney, except if you have a very high glomerulosclerosis that you might need to rebiopsy. But that is, again, a different step. But we should not solely make the decision on accept or discard an organ based on the biopsy alone. And I hope this was of interest for you. And I hope that the future of solid organ transplant and disease donation in Oman is bright. And I hope in the near future to see Oman transplantation activity increase as well. Thank you very much.
Thank you very much, Pedro, for the excellent and useful presentation. Now we have 15 minutes for questions. I invite you, the participants, to open the microphone and ask the question, or you can write in the chat if you prefer. Pedro, when we waiting for the other questions, I'd like I have some questions, but I will start with one. In the practice, in the hospital clinic, when do you decide to do a biopsy, and when you put the kidneys on perfusion machine? When you decide to use one, another, or both? I don't know if you use both.
A great question, Mauricio. And in the talk, I didn't move towards the perfusion machines because I think that's a totally other specific topic that needs to be addressed, I believe, separately.
Sorry. I talk about that because some people,
it makes
some
sense.
countries, the people are starting the programs, but just talk about the perfusion machine. Yeah, like a solution.
I agree with you. And first and foremost, clinical practice. We've been doing kidney transplants since 1965. So we have 50 years now of 60 years of kidney transplantation. And the cold storage has worked for the most part of it. So cold storage is a perfect and amazing technique for organ preservation ex vivo. So you must keep that in mind. And I think that's the first and most important message, that cold storage is a very good preservation technique. As for the machine perfusion, we do use it. We don't use it on every kidney, not for a million years. We use them on. We used to use them on extended criteria donor, and that we would include them on hypothermic machine perfusion in extended criteria donors. we would use them on DCD type 2. On Maastricht type 2 donors, we would use on anyone, regardless of the age. We would include the kidneys on the hypothermic machine perfusion, and also on DCD type 3 if they fulfill the same criteria for extended criteria donors. And the reason to include these kidneys on the machine perfusion is not necessarily to expect better outcomes from it, because up to date, I think there's still very few publications that have solidly demonstrated that hypothermic machine perfusion improves graft outcomes. The solely reason to include them is we use them as an additional parameter to evaluate the organ perfusion, meaning particularly for DCD type 2 and DCD type 3 with extended criteria, we observe that the resistive index in the machine perfusion after 4 hours correlated with the risk for early graft failure, not for long-term graft function. Including the kidneys on the machine perfusion, and we compared this because a lot of the kidneys, because they have 2 arteries, because of logistics, sometimes we cannot include them on the machine perfusion, hypothermic machine perfusion. We observed that there were no differences in graft outcomes, whether they were on the machine perfusion or they were not. And we even had some kidney pairs because one had 2 arteries and the other didn't, or because one, we only had logistics for one machine perfusion at the time, and we did not observe differences on graft outcomes in the ones that were on machine perfusion and the ones that weren't. So I know that machine perfusion, particularly hypothermic, is a major topic nowadays. I think it's important, but it's not necessarily need. There's a difference between importance and need, and cold storage has worked fine and perfectly with good outcomes for decades, and I think we keep that in mind before we embrace technology and the costs of that technology. We need to be sure that it leads to improved outcomes on the long term, and we need to be sure on what data we're extracting from there. So just to give you an example, if any of these organs, we basically add up. If we then have a Remusi score of 4 or 5, and we have the kidney on a machine perfusion, and we see that the resistance index in the first hour moved from 0.9 to 0.8, you can already see that the slope of improvement of the resistance index is low. But then you go to the Remusi score and you have a Remusi score of 5, and you can see that most of it is due to arterial ialinosis. So you know that this organ, it's likely have a very thick arteries. So it's likely they have a very high resistance due to the thick arteries. So it's likely that on the long term, if I put it on a patient that has diabetes or hypertension already, that I'm just going to add up factors. So sometimes I decide to move this organ to a rather lower risk recipient in the setting that I'm not adding insults to that organ after the transplantation. So it aids on the decision making on the matching between donor and recipient, not necessarily on the discard or not discard organ. And I'm not sure if I made myself clear. The biopsy, the criteria is the same. Extended criteria donor from DBDs or type 3 that are older than 60 with the same criteria as extended criteria donor, we'll do the biopsy. But we'll do the biopsy as an aid for decision making. And sometimes when you have a Remusi score of 4 or 5 in one kidney, but you have of 2 or 3 in the other kidney with very low glomerulosclerosis, if the glomerulosclerosis is low, we'll still accept the kidney for transplantation, because we've seen, and I showed you, that the major impact on graft outcome is on glomerulosclerosis and not on any of the other histological parameters. So this would be my thought process.
Excellent. And sometimes the biopsy is not only support the decision to use the organ, but about the immunosuppression and the managing of the case.
If you have already thrombi in the biopsy, it's likely that you decide to delay the introduction of the tacrolimus, because you're just going to add factors to extend that TMA. Or if you have again a very thick ialinosis, or you might not use, or you have a high percent of sclerosed glomeruli, you might decide not to use an mTOR inhibitor, because that might just increase your proteinuria, and then the proteinuria will reduce graft survival in the long term. So yes, indeed, it aids you on the decision making of the immunosuppression, also on understanding what happens afterwards. You'll have that patient that will get a steady state creatinine of 2.1, and he's perfectly functioning. The patient, the kidney, they have a good volume balance, they have a good electrolyte balance, but still the creatinine is 2.1. And then you go back to the pre-procurement biopsy and you realize that there were donor lesions there, and that might explain you for those 2 of creatinine. So you might not be too aggressive on doing post-transplant biopsies or on increasing treatments because you already expect that outcome from the graft function. But on long term, you know that patient might just sustain that 2.1 serum creatinine for 5 or 10 years easily.
Excellent. Do we have any questions from the participants? We have one question in the chat, but it's about the benefits of the use of the machine perfusion in extended criteria that you just commented.
Part of the question is on the... Yeah.
Please go ahead.
Yeah, okay, Dr. Pedro, what parameters or investigations that you expect to receive from the donor coordinators to evaluate the kidney?
From the donor, our standard minimum is the gender, age, height and weight. You have to have previous medical conditions, in particular, always focusing obviously on hypertension, diabetes, history of kidney disease in the patient or in the family, or any other medical conditions from the donor. Then we need to know what's the cause of death, definitely. When was the time of hospital admission or of the major event that led to the patient outcome? If it was a stroke, what was the date of stroke? And then again, what were the number of days of the patient on the ICU? How was the condition of the patient on the ICU? Was hemodynamic stability? Was it not? Was it vasoactive drugs? Did they have insipidus diabetes? Did they need to use desmopressin? You need to know what's the kidney function, serum creatinine, and proteinuria. What was the urinary output within at least the previous 48 hours? If they have at least an expected what was the story within the time on the ICU, and the more the better. You need an ultrasound. You need to know what's the kidney size. You need to there are no morphological abnormalities up front, and then you need to understand whether the size and the echogenicity of the cortex of the kidney is normal. You need to understand that before upfront. And I think upfront, those would be the major criteria that you would need from the donor. And obviously you need to know if there were any cardiac arrests prior to the organ donation, if there was any episode of acute kidney injury prior to the organ donation. Those clinical data from the donor, you also need to know them. But upfront, these would be the major criteria that you need to know from the donor, in addition to serological data that you then need to adjust for the recipient.
Excellent questions. I have only one comment, because sometimes we as a transplant team, we think about the biopsy, machine perfusion, but the information about the donor, deceased donor, is really important for us to decide if we use or not the organ, and the quality of the management of the donor. Okay, if I have one extended criteria donors, 70 years old, but the quality of the management was good, no hypotension, no electrolytic disorders, and no acute injury. This is totally different. You consider use this donor if I have one very poor management quality in the other case. Then this is very important information, no, Pedro, for us like a transplant nephrologist.
It's the donor management is more than 50% of the success of the deceased donor transplant. And just to give you an example, in Brazil, and I'm not mentioning countries for any specificity, just because a very specific example, and at Mauricio, this is not personal. In In Brazil, even young donors, like kidney pancreas transplant donors that usually are younger than 40, the incidence of delayed graft function is almost 50%, meaning the incidence of the need for dialysis after organ transplantation is almost up to 50% compared to the standard or accepted standard around here in Spain. In that type of donor, we would expect around 10 to 15% of delayed graft function. So the donor management is the culprit for post-transplant outcomes. So what Mauricio just commented, that we need to understand in depth, and we need that information on how was the donor managed and how was the donor condition during the ICU. It's really relevant towards acceptance or not of a potential donor.
Yeah. Unfortunately, in Brazil, we have a very, it's not in all states of the country, but we have in many states the high level of the delayed graft function because the poor management. Pedro, we have, I don't know if you have the last question. If you don't have, I will have only one question for you. I'd like to invite you because in Oman, we have this scenario. They have in the beginning living donation, and now they are starting developing disease donation. And I know that in these cases, for the transplant teams, we are adapted to use the ideal donors, that's the living donor. And when we start receiving offers of the extended criteria donors, in general, the team feels not too comfortable, too acceptable. If you could give some tips, okay, in 1 to 3 minutes, some tips, how what would be your suggestions to start the disease kidney program and could use some extended criteria donors?
First and foremost is as transplant surgeons or nephrologists, we need to be aware that we cannot expect the same outcomes as for living donors at any age. We cannot expect it either at 20 years old living donor, just as a 70-year-old donors. We cannot expect the same outcomes regardless of the age. And for not the same outcomes, I'm not talking about early graft failure, because on that, I think we must focus on the same patterns of quality as for living donation. But regarding delayed graft function and regarding serum creatinine and eGFR in the post-transplant period. So having that in mind, and if we accept and embrace that and we are comfortable, we will be comfortable to explain this to the patients. Because what the patient must be aware is that getting a transplant, even if they get a serum creatinine of 1.5 milligrams per deciliter or an eGFR around 40 or 50, that's a good outcome on the long term. So if you're planning on doing an extended criteria donor protocol, the first and foremost is that you rely on the age and obviously on the comorbidities. But if you use extended criteria donor that have rather low comorbidities, and then you can try to reduce your cold ischemia time, regardless of what you have, of if you have machine perfusion, hypothermic machine perfusion or not. If you reduce cold ischemia time, that's the two best measures to improve graft outcomes. Secondly, don't use the biopsy to discard unless there is a very high rate percentage of glomerulosclerosis. The biopsies are very bad biomarkers and they have a very high impact on logistics. And if you cannot do the biopsy, this does not mean that you should not proceed with your transplant program. And third is to use immunosuppression protocols that reduce the risk of infections, particularly on the recipient. If you're using extended criteria recipients, don't aim at increasing immunosuppression. That's what we observed, that we had a higher risk of infection in older recipients, because as you move towards extended criteria donor, you also move towards extended criteria recipients, and with that, you increase the risk of infection. Nonetheless, keep in mind that with extended criteria donor, with the risk for increased ischemic perfusion injury, you have an increased risk for rejection. So the risk of rejection is also higher if you use external criteria donor, but the rejection is treatable and the long-term outcomes are similar, are the same compared to DBDs, compared to standard DBDs. So we cannot compare living donor to deceased donor. That's not comparable. That's like comparing type 1 diabetes to type 2. It's different. It's different pathophysiologies. The outcomes are different. So we need to compare DBDs and deceased donors to dialysis. That's the comparison that needs to be made. And the comparison for you is your patient on dialysis better than with a transplant from a external criteria donor? No. He will be better with a transplant with an external criteria donor compared to being on dialysis. On the long term, 5 years down the road, he's going to be better with a transplant. So if you don't have an ECD program, what you need to establish and understand is that the risk of rejection is higher and the risk of delayed graft function is also higher. So you need to have a plan on to do dialysis within the first week, 2 weeks of this patient post-transplant. And you need to use a little bit higher immunosuppression than you would use for your standard criteria donor. And then regarding organ acceptance, if you're starting a program, accept these ECDs, but try to focus on those that have a lower comorbidity, preferably patients with hypertension, with smoking, but that don't have an acute kidney injury, but it's very transient, it's very short. Patients that have diabetes, very short term, or they are not insulin dependent, definitely diabetes, but not insulin dependent. So focus on starting the program to start understanding, expecting results and rather good results, reduce cold ischemia time, start with donors that have some low comorbidities, regardless, except for the age.
We have only one short question, and you can give a short answer, please. It's about for us, we are not still have a specific protocol regarding extended criteria donors. What's your advice about using the pathology score or KDPI or both together? As I do believe in extended criteria, still pathology score would help to decide about the dual transplant on or single recipient in the specific case.
I understand the question, but let me put it this way. If I was to start and getting experience in a deceased kidney donor or extended criteria donor, I would not start with dual transplant. It increases the surgical complexity, and it's also, if then the results are not as expected, it will be hard to understand whether it was the dual transplant, it was accepting a high Ramusi score. So if you're doing a biopsy and you're starting a program, I would start by transplanting those with a Ramusi score of 4 or lower, not those with 5 or 6, and do a dual transplant based on a Ramusi score of 5 or 6. Because basically, sometimes when starting and ramping up a program, one faulty case might be a major drawback. As to the KDPI, I would rather use the KDRI than the KDPI, because the KDPI gives you an estimate of graft function on the long term. But if you're going to quantify the KDPI, it's going to be to the US population. It's not going to be to the Oman population. So unless you develop and you adapt the KDPI to the Oman population, and you have a very large number of deceased donor transplants in Oman, and you establish the same formula to Oman, otherwise you will be relating your donor quality to the US standards. And the US standards, and we just talked about it, are based on some standards on organ preservation and donor management that might necessarily be the same as in Oman. So I would not decide based on the KDPI. I would go back to clinical data, maybe use the KDRI as a reference, but not necessarily for discarding organs, mostly for evaluation and adding the KDRI to the pathology score. If I have a Remusi score lower than 4 in a KDRI of 1.3, even if it is an ECD, maybe I think that would be a suitable organ if I can transplant it within the first 12 hours post-organ retrieval.
Excellent. Because the time we need closing the session, for me, what's excellent discussion. Thank you very much, Pedro, for every inputs that you send us. And thank you, the participants. We had more than 25 people in this webinar, and I'd like to say thank you, everyone, and see you in the next webinar. Okay, bye bye.
Thank you.